Okay, I'd like to start by thanking Dr. David Rosensweet and Dr. Jonathan Wright for joining us today to give a brief preview of the Menopause and Andropause post-conference workshop in Las Vegas on December 14th. All information for this workshop can be found on a4m.com. I'd like to go ahead and pass it off to the doctors, so go ahead.
Hello, I'm Dr. David Rosensweet, and Dr. Wright and I are presenting a full-day seminar at A4M in Las Vegas, Sunday, December 14th, entitled Menopause and Andropause, Increasing the Health and Happiness of Your Patients with Bioidentical Hormones. In this 20-minute program today, we will introduce you to the subject by interviewing each other about it. I'll begin. Dr. Wright, you have been a physician for 45 years. You are the one who launched bioidentical hormone usage into popularity in the early 1980s. How about distilling all that you know down to your top 10,000 list, then sharing your top 3 pearls right now?
Okay, well, thank you very much, Dr. Rosensweet. I'd say the top 3 things about bioidentical hormones can actually be summed up into one, but then I'll split it into 3, and that is we always should copy nature as closely as possible when we're doing this, simply because it's not exactly natural to have hormones after menopause, but on the other hand, if we do the cost-benefit analysis, yeah, the benefits are greater than the costs, so let's copy nature as closely as we can, and we're likely to make the least mistakes. And what that means is we want to be using molecules that are precisely identical to what were there originally in greater numbers, of course. We want to be using them by the route of administration that they should be, and namely, they need to go straight to the heart first and be distributed all over the body. I know of some instructors who are still telling people to take their estrogen orally, and of course no one has their ovaries sewed into their intestines to where the estrogen goes straight to the liver first, so of course that causes disruption. That's not copying nature, and then the other copying nature part of it is the timing that nature uses, and we should copy that as closely as we can. And, of course, the quantity, and we don't want to exceed what's usually found in the body of those hormones. So, again, it's copying nature broken down into those elements.
Excellent, yes.
All right, sir. Well, I get a yes, I get to ask you something. Oh, good. Let's see. Let's do your top importances, and you can pick the number of importances, for hormones for women. Why are they important?
Well, yes, thank you, Dr. Wright. They're very important in general. You know, at the time of the perimenopause and the early menopause, mid-40s and mid-50s, women's hormone levels declined dramatically, and there are very significant consequences of this. Many women are quite familiar with the consequences, as they have rather raucous or mild, medium, or large symptoms of hot flashes and night sweats, and their sleep gets disturbed, and oh my goodness, disturbed sleep for a couple of nights, and you have a rough road in conducting your day-to-day life. But there's a lot of women who don't have the severe symptoms, and they attempt to ride it out. But one thing, most all women, that's quite a statement, are going to undergo the deleterious effects of hormones diminishing. And you wind up with the risk of cognitive decline, ranging anywhere from a senior moment to very significant and serious cognitive declines, even heading towards the worst of the cognitive declines related to low hormones, and risk of arteries being hurt by the low hormones for a variety of reasons, and risk of the bladder and vagina having issues to the point where women get cough incontinence and have to wake up at night too many times and even lose their urine frequently enough to have to wear Depends. Women do not like this at all. And there's other deleterious effects of hormone loss, and how I see it is that there's almost a guarantee of adversities over the course of years from insufficient hormones, estrogens, progesterone, and the androgens. So that would be a great. Could we sum that up,
Dr. Rosensweet, by saying that for women, hormones allow her to be continuing to be a woman and not a little old lady, and minimize the chances of little old ladyhood. And for men, testosterone does the same thing. It allows a man to go on being a man and not end up being a little old man.
That's a lovely way to sum it up. All right, well, let's see. The topic of hormone treatment is often associated with fear of risks, Dr. Wright. Would you please comment on the risks for males as far as hormone usage goes?
For sure. The legitimate risks, as I've seen them over the years, and as you pointed out, that's a number of years. It wasn't 45, but it goes back to 1982. The legitimate risks are, the big ones are these. 1/3 of all of us out there have a predisposition to type 2 diabetes. At least that's according to whatever government agency keeps track of those statistics. And I believe it from what I see. And men who use testosterone and may be on that path, even if they don't have type 2 diabetes yet, will transform too much of their testosterone into estrogen, and if they're not careful to monitor that and deal with it, that is not good for a guy, and particularly his prostate gland, but other organs too. So that's one risk. And no, I can't stand the knee-jerk response of some clinics. Here's your testosterone, and here's your patent medicine that blocks it from going to estrogen. That's wrong, because if we just do that and don't pay attention to the fact that the reason that's happening is he's on the road to type 2 diabetes, fine. He's not going to have too much estrogen, but he'll end up with type 2 diabetes because he's ignoring what makes the testosterone go to estrogen, which is that high insulin signal due to insulin resistance. Everyone listening knows about that. But some clinics just knee-jerk, and here's some of that patent medicine, rather than, oh, as well as working on your testosterone, you need to work on not getting type 2 diabetes. And we do have a whole discussion about that during this seminar, how to prevent and treat type 2 diabetes before it ever happens, so you never get it. So that's another one of the things. Second big risk is some guys' bone marrow responds to testosterone by making too many red blood cells, or too many for them, let's put it that way. And when the blood gets thicker and more viscous, we're more prone to cardiovascular events. So that has to be monitored very carefully, too. Insofar as all the other things that we're told are risks, they're pseudo-risks, and they're dealt with very effectively by Dr. Morgan Taylor in his book, Testosterone for Life. One of the basic ones being that no, testosterone does not increase the risk of prostate cancer. But the two real ones are, again, ignoring the tendency of type 2 diabetes and letting the guy end up with too much estrogen or doing the knee-jerk response without treating the overall problem. And number two, too much blood thickness, too much blood viscosity, and the risk of heart attack. And that's easily checked against by doing a CBC. Okay, well, let's go back to that same thing for you, Dr. Rosensweet, risks for ladies.
Well, I began to mention them, and I had left out of my initial list the risk for bone loss. And, you know, osteopenia and osteoporosis, and especially osteoporosis, it can be the bane of the elderly. It can be one of their last events. If you fall on an osteopenic hip and fracture that hip, it can lead to tremendous challenge for the patient, for the families, for the medical care system. So bone, brain, I mean, if you follow out the risk to brain, how many menopausal women have you interviewed, Dr. Wright, who have said with one of their leading symptoms is, I'm not thinking clearly. Here I am. I'm functioning in a profession that's very important to me, or functioning as a mother, or however I'm functioning, and I'm not functioning well. And our literature clearly points out the spectrum can get much worse than that, and it can even be a risk for some of the worst dementias. So bones, brains, vagina, I was covering this. I mean, not to mention intercourse, which many women do want to continue, and not all do, but when the vagina gets thin and it irritates the urethra, you get situations of frequency, nocturia, and as I mentioned, you eventually get to wear some kind of form of diapers, which is a very significant bane to many women.
Now, what about the other side of risk, though, the risk of the hormones actually causing problems? That always gets asked about.
Oh, sorry, yes. How important is that? Well, to cut to the chase, and I'm going to give an opinion here, and one of my loves is the medical literature, I'm going to assert that there's never been a hormone in natural dosages that has caused cancer. And, of course, that's the big concern that has emerged out of the Women's Health Initiative, a study that had many faults. Now, why is it of any alarm whatsoever? Well, most interesting, even Premarin itself, horse urine-derived estrogens, half of which are not even found in the human female, that actually in the literature points out to us that the risk for breast cancer and cardiovascular events and stroke is less than not being treated at all. And when you take that into the bioidentical world, that's Premarin. That's not Prem-Pro. That's not the combination of Premarin with a very funky molecule, a very distorted version of progesterone called a progestin. That molecule, Prem-Pro, is a problem. And what the Women's Health Initiative did demonstrate that there was an increased risk, albeit very, very low. And albeit the study demographic had many faults to it, so there's problems in the research that once the cat got out of the bag, however, it scared so many women but Prem-Pro was a problem. Not so bioidentical hormones, those molecularly identical copies that you mentioned. They're identical to what the human ovary produces. Again, we see reduced risk of breast cancer, of arterial disease, et cetera, et cetera, et cetera. So the risks are lessened by bioidentical treatment, hormone treatment, as opposed to not being treated at all. Now, there is an exception. Right. The cause of cancer, I mean, you know, all of us become vulnerable to illness if we're not taking really good care of ourselves, or even for reasons unknown. We become, as we grow older, and, you know, we're talking about the 40s and 50s and 60s, these age demographics, we're vulnerable, and a certain number of us are going to develop a cancer. And the interesting thing is, in the world of women, is if they have a well-differentiated cancer, where the cells themselves are very similar to the breast glandular cells from which they derive, and if they have estrogen receptor sites, because they're functioning like a breast glandular cell in many ways, they're just out of control growth-wise. If they have those estrogen receptor sites, and you give a woman estrogen, it's likely that that cancer is going to grow a little more rapidly than it would. And this is where the confusion becomes. Now, again, I'm going to state it, that the cause of cancer is not the hormones. But if you have an estrogen-positive receptor site, well-differentiated breast cancer, it's probable that if you treat that woman with estrogen, it's going to grow a little faster and become apparent a little faster and be treatable, identifiable and treatable. So there's some information about risks. But in general, I'd like women to think that for the vast majority of them who aren't creating cancers already, that the treatment with bioidentical hormones reduces their risk for cancer, for stroke, everything that we have been that we have feared. The risks are reduced.
All right.
All right. And Dr. Wright, would you tell us about an anti-carcinogenic testosterone metabolite? And can it be increased endogenously or be prescribed?
Yes, I certainly will, but I'm going to intrude slightly into your territory, sir, and remind everyone listening that there are two proven anti-carcinogenic estrogens, and they both can be prescribed, and you'll hear more about that at the seminar. Now, as far as the anti-carcinogenic testosterone metabolite, it's actually a metabolite of that stuff that has such a bad reputation, DHT. And that particular metabolite contacts only what's called estrogen receptor beta, which most everyone knows is an anti-proliferative reorganizing receptor. And in experimental animals, when this particular testosterone metabolite is used, what do you know, prostate cancers have been shown to regress. And we'll have the appropriate citations for people who'd like to look it up and read it. Okay, can we prescribe this stuff? Well, not presently. I was able to prescribe it for about 6 to 7 months, about 4 years ago. And then oddly enough, a certain government agency somehow managed to stop the transportation of it into our country from Europe, where it is used. So there are ways that have been shown to raise our own levels endogenously, and I'll be going over those. There are at least 4 substances and maybe a 5th that are all found in nature that, if they're used, we can raise our anti-carcinogenic testosterone, and, of course, the pro-carcinogenic goes a little lower. And very importantly, there's actually a test for this that will test the testosterone. It'll test the DHT itself. And by the way, we should be calling this 5-alpha DHT because there's a 5-beta that nobody pays attention to, even researchers. So it's 5-alpha DHT, which is getting the bad reception. And then that 5-alpha can go down 2 channels to the pro-carcinogenic and the anti-carcinogen. And that can be measured. And then if it's abnormal, it can be changed endogenously. Now, we're still working on trying to get it prescribed, but unlike the estrogen metabolites, it's presently not available on prescription. And, sir, I think it's my time to bug you about something. Hey, what do you like about working with bioidentical hormones for ladies?
Oh, well, my goodness. You know, both of us have always been broad-based general physicians from right out of the chute and always interested in any additional tools we can pick up. And what I noticed about treating women in menopause was they often would come in with raucous symptoms. They often were basically healthy and with some small, medium, or large attention to their issues in the prescription of bioidentical hormones, they got back on track in big ways that they were very grateful for, and it was very rewarding to them. So that was always rewarding to me when a patient can turn and say, my goodness, this has been good for me. I really appreciate that. You know, I've been always worked with all kinds of people with all kinds of situations, and sometimes, and especially some of the more substantial illnesses, it can be a long piece of work in which many times good things can happen, and sometimes it's not so immediately and clearly rewarding. But menopause was really different for me. It was much like delivering babies. You know, there wasn't that much to do, although the body of knowledge has expanded enormously since I began. There wasn't that much to do, and the rewards were very obvious and great. And also, I'm a lover of biochemistry. I'm a lover of the physiology of all this, so it's fascinating to me to play with these molecules, establish the balances, get the dosages right, walk out the process, and then see this wonderful, elegant testing we've got, these 24-hour urine hormone tests, which we'll have a lot to say about in the seminar, that allow us to work with a level of accuracy that is very rewarding to see the numbers, see how they correlate with the patients, but most of all, it's how rewarding it is for a woman to be able to note in a small or moderate amount of time that she feels ever so much better, and she's jumped back into her life and her mind and is very grateful for it.
Yes, that definitely. I concur with that for sure.
All right.
As far as working with men, I'd have to repeat what Dr. Rosensweet had to say, namely, guys will get some things back. They don't misplace their keys as often, and they're able to exercise a little better and so forth. But of course, hormones for men don't drop as abruptly as women do, so it's not necessarily as much of a dramatic effect. It's just, oh yes, I'm back to where I was. But, you know, one thing that'll get a guy to come in to see a doctor is testosterone. It really is. And so I have the opportunity there to see men that I wouldn't see otherwise and to look over their general health and to say, oh, by the way, now that we've got this underway, did you know that if you did this and this, that over there might get better, that's in your new patient form, you filled out that you have this problem and that problem, and I know you didn't place emphasis on them, but it's one of the, as we all know, women are usually the health officers in the family, and a lot of times guys go to the doctor until something's been hurting for 2 years, something like that, or their wives push them in. But testosterone will get them in there in a flash if they think they need it. And so it's an opportunity to go over general health that I wouldn't otherwise get with many men. And most of the men, particularly after they notice what the testosterone did for them, are more open to other suggestions. And since it's coming from a, let's call it a bioidentical or natural medicine point of view, they may not have heard that point of view even ever before. And so they're more open to it because the testosterone has helped them some. So, okay, maybe I will try the next thing that's recommended here rather than ignoring my health, except for my testosterone for the next 20 years.
Excellent. Excellent point.
All right. Now, we have a couple of other topics in the seminar besides estrogen, progesterone, testosterone. One of them I mentioned already, how to detect and reverse type 2 diabetes before it ever occurs. That is very possible, very, very possible, and we'll go through that. And the second thing is we're including some work on thyroid hormone.
Yeah, would you opine on thyroid testing? I love including thyroid in our seminar.
Yes, and of course it's another bioidentical hormone, and it does interact with estrogen, and it interacts with the adrenals and so forth, so it's important. One thing, the type of thyroid testing we were taught in school, there's just a wonderful paper out there which we'll be reviewing that shows that really, really, really we should not be relying on blood tests at all. In fact, that's a matter of treating the laboratory and not the patient. And we should be relying on the history, the physical exam, and the lab tests. And the lab test that's most important is not the TSH. Okay, that we'll be reviewing. We'll also be, and why, the whys of it too, not just stating it outright as doctrine or anything, but here's the reasons. Okay, we'll also be going over a wonderful protocol that was originated at Bethesda Naval Hospital in 1984 that most of the time gets hyperthyroidism, Graves' disease, indeed. The bad symptoms of it, the elevated T3, the elevated T4, and so forth, gets it under control within a week or two. And I'm not kidding, folks. And I didn't make this up. It comes from Bethesda Naval. I've put it into effect since I read about it, and it works nearly every time. Now, one has to do more to get rid of the underlying condition that led to the hyperthyroidism, but to get rid of the shakes and the tremors and the sweating and the anxiety and all that goes with Graves. Yep, a week or two, and we've usually got it. And then the last one has to do with a really good study that one of my colleagues did, Dr. Davis Lamson, taking a look at some 2,200 complete thyroid panels. And he was suspecting this, but much to everybody else's surprise, what he found is the most often abnormal test on a complete thyroid panel is not the TSH, it's not the T3, it's not the T4, and we'll get to what it is and what the meaning of it is and what can be done about it in order to help normalizing things. And a clue, it isn't giving thyroid hormone. That's not what normalizes it. So anyway, those aspects of thyroid we'll be going over, and probably a few others.
You want to throw a ball at me here?
What's this now, sir?
Do you want to throw a question my way here?
Oh, my goodness, I must do that, absolutely. Let's see. You were telling us about dosages, and I really have to admire some of the calculations that you're going to lay out to show us about dosing. A lot of what you tell us, Dr. Rosensweet, we can take home and do in our own practices. And I try to do the same thing, make it information you can take home and do right away. But you do even better than I do, sir. You've actually got ready-made paperwork for folks who are just getting into this, so that if they want to use those forms, they can use those forms, and here's what they mean. And certainly somebody who's been doing it for a while might not need them, but then they might not be attending the seminar either. And I love that you make that available to everyone. Tell us about those forms, please.
Well, over the years, I've discovered that every single part of the process of working with menopausal women can be improved or made easier for the woman and easier for myself by, right from the beginning, by establishing a questionnaire that they can fill out in their home and bring into the office. And it's quite extensive, and it focuses in at one point on the hormones. And so you can learn so much about a woman's hormonal balance just from our medical history. So we zero in on that part. We zero in on the formulations themselves, because I've become a fan of using carriers that aren't solvents, and so we provide that. We have means of giving women a DVD in which they can learn how to apply the hormones and also how to titrate dosages. A subject that you and Dr. Gaby and myself and now so many physicians are applying to the world of treating patients. And so we try and automate in some way to make everything, the process simpler, less expensive, less repetitious to the staff. And we also, I care a lot about, as you do, about the dosages. And basically, we're reaching for optimal dosages sufficient to alleviate the symptoms and to protect against some of the possible adversities of lowish amounts of hormones, and at the same time not to move into excess. And we're careful. That's really at the low end of things. It's a surprise of how low these dosages can go. We do not need robust or youthful levels to get so much of the good, if not all of the good, of what's required in almost every single woman. And we teach doctors, as you know, in our seminar about what are the numbers. How can you look at a biased formulation and know how strong it is and how much estrogen a woman's actually getting? So we have spreadsheets that automatically calculate it. We teach you how to do the math. So it's every step of the way. We try and make it Monday morning applicable so that a physician can go, or a nurse practitioner can go out into their practice and have the various tools that make the whole process simpler and more thorough and complete, including follow-up questionnaires as well.
Yeah, when some of us hear the word automate, we start thinking, oh my goodness, I got into all this because I don't want to do cookie-cutter medicine, and automation sometimes means everybody gets the same. And in Dr. Rosensweet's system, that is not at all. It's automatic. It's automated individualization. It is not automated cookie-cutter. It's how to get it done more effectively for each individual and what she needs, rather than, oh, here's the standard dose for everyone. And I just love that, and that he makes these available either, I believe, isn't it, David, to download, or you'll mail them to them, and as part of the seminar, no charge.
And thanks for clarifying that, because if there's several basic laws, so to speak, of menopause, and one is it has to be individualized. Every woman differs so much according to what she needs, how sensitive she is to what you give her. So yes, it's not the actual process that's automated. It's just making simpler and clearer and more documented the various aspects of the process. Thanks for clarifying that, Jonathan. That's a big one.
For sure. And it allows people who are new to the field to be able to be more confident by using Dr. Rosensweet's system for women, to be able to be more confident that, yes, they're getting right to things, even though they're just starting.
Perfectly said.
And for those who aren't just starting, there's always a point or two to be learned. I know I learned a few things from reading through those forms, so thank you, David.
And I've been attending. We've been doing this together for quite a while, and it isn't a single year that passes that I don't learn a whole bunch from you again. Oh my God, there it is, more information that I hadn't even considered before.
For sure. Okay, are we getting to the end of our time, or do we have time for something else?
We are. There's a time. Let me ask you a question here, and about the anti-carcinogenic estrogens. I mean, this is something we emphasize. You've emphasized since the early 1980s, and now in a new way. Would you address that topic?
Yeah, and I'll pick on a particular circumstance which we all hear about sometimes. Women who have survived breast cancer, and we hope that everyone does, but women who have survived breast cancer, and yet they're still not feeling like they felt before. Not that they're hot flashing all over the place, but still it's on the way to little old ladyhood, not exercising as well, and so forth. And can we do anything about that? Well, yes, we could go ahead with the regular bioidentical hormones and monitor closely, but we can do one other thing. The two currently available for prescription anticarcinogenic estrogens, one is estriol, and the other is something called 2-methoxyestradiol, and these are both prescribable. I work with a number of women who use that combination for their estrogens, of course. It does not replace progesterone. And what Dr. Rosensweet has worked out is an exact calculation of the relative potency of the estriol to the usual 17-beta estradiol. And the reason we want to know that is estriol contacts, of course, just estrogen receptor beta, which makes it anticarcinogenic, but those happen to be the happiness locations in the brain. It improves mood, it improves affect, it improves all the emotional things, which may be why pregnant women are usually a lot happier, or at least somewhat happier than they are other times. But that's worked out in publications on estrogen in the brain. The beta receptors are mostly in the mood, affect, and happiness areas, and the alpha receptors have more to do with the reproductive functions, which at that point a woman's not so much interested in reproducing anymore, usually, especially if she's had breast cancer. So anyway, there is an equivalency, a certain amount of estriol, which will just perk that mental health right up. Now, the 2-methoxyestradiol, that one is doggone potent. That it has been in phase something or other, 2, 3, whatever they are, trials with FDA to be, quote, approved, unquote. But you know what? I'm sorry to tell you, everybody, the manufacturer lost interest because they came up with 3 patentable molecules that would do the same job, and of course, with a lot more potential side effects because they're patentable. So it doesn't look like the trials are going to go that much further. But while they were going on, oh my goodness, it was found to be a very useful thing in the treatment of prostate cancer. No kidding, it's an estrogen. Breast cancer, ovarian cancer, bone cancer, all sorts of cancers. One of the latest publications I saw was from the Mayo Clinic, and they actually found that it helped with regression of metastatic cancer, and that's 2-methoxyestradiol. So we use a combination of those two. For the ladies who've had breast cancer, they feel better. They've got protection from the 2-methoxyestradiol, which is very powerful protection. And very importantly, we can monitor levels to make sure, particularly that these, since they're anticarcinogenic, are staying in the upper end of normal rather than being low normal. And a woman's fat cells are going to make some of the other estrogens, but still, if we outnumber the procarcinogens with the anticarcinogens, then she has her best chance. And notice I didn't say it's a perfect chance, but has her best chance of being able to use estrogens and not setting off a problem with those estrogens anyway.
Such a major gift to those important women.
Yeah, the ones who've had breast cancer and are told, oh no, you should stay all the way away from hormones. And of course, it has to be balanced with progesterone and everything else as is usual. But even so, it makes it a lot safer.
And if I might put in a plug for treating elderly women, something that we covered during the seminar, it's been a newer area for me and a very rewarding one, because some of the meeting up with women in their 80s and 90s who are actually experiencing these major cognitive declines and the major loss of their bladder, their normal bladder function. It is so rewarding, as well as administering the androgens, which is a very important topic in treating women. Sooner or later, every single one of them is going to need it. I know that's a pretty broad statement, but that's sort of been borne out by my testing experience, that sooner or later, 2 to 3 years into menopause, these androgens are going to decline, and they lose muscle mass. They get sarcopenia. Talk about the bane of the elderly. They get sarcopenia, their muscles get weak, and they can't maintain their balance, and they fall, and they fracture their bones. So being able to alleviate or reverse sarcopenia and the bladder issues and the cognitive issues is extremely rewarding. So we go into a section on how to treat these elderly women, because it's not necessarily the same. It has to be simplified. It has to be made so that they can comply with it, and we've got methods of doing that. So we also go into that in our seminar.
And we may sneak in another hormone or two, just little bits. We only have one day, but we may sneak in. And here's one that we may sneak in. Very recent research showing that oxytocin is a major factor in muscle regeneration and maintenance. And the researchers who did this got right down to the biochemical pathways by which it works and pointed out that oxytocin stimulates muscle cell stem cells. Wow. And that's how it helps to maintain and regenerate.
Yes, so, my goodness.
And there are tests for oxytocin, folks. And as we get older, all the hormones decline. So I make sure, as David says, And if we don't want someone to turn into a little old lady or a little old guy, the testosterone's got to be there in woman doses or man doses, depending on how you're dealing with. But we better look at that oxytocin, too. So anyway, we'll sneak in some other hormones here and there.
Well, should we continue, or shall we just wait for the seminar where we have a full day? We could.
There you go.
Yeah.
I think we better do this, or we'd be on the phone a full day.
All right.
We better wait for that seminar, yes.
Always fun to connect up however we do, Jonathan, and I look forward to our event together as always. Big fun.
For sure. And, hey, folks, I've been known to tell a bad joke every once in a while, but that's a very minor part of the program, and you need not laugh.
Well, I thank you both very much for taking the time to share this preview with us. If anyone would like more information or to register, you can call 888-997-0112 or visit www.a4m.com. And we look forward to seeing both of you in December.
Thank you, Jordan.
Thank you so much, Jordan.
Thank you both. Have a great day.
And you too. And thank you, everyone.